Once you've had breast cancer surgery, radiation is often the next step in your recovery. Here to tell us about a very effective and less invasive radiation procedure is Dr. Douglas Arthur, Chair of Radiation Oncology at VCU Massey Cancer Center. Welcome to Healthy with VCU Health. I'm Aileen Ellis. Dr. Arthur, thanks for joining me. What is APBI, Accelerated Partial Breast Irradiation?
So let's sort of give you a little bit of background and then we'll go right into it. So for early stage breast cancer, those women with relatively small tumors, negative nodes, they have the option to either have a mastectomy plus or minus reconstruction or preserve the breast by removing that area with a rim of normal tissue and then following with radiation therapy to take care of any microscopic disease that might be left behind, thus giving you the same results from a mastectomy or with breast conservation therapy. Traditionally, that radiation has meant treating the whole breast, and it was started with a Monday through Friday, break on the weekends regimen where you come in every day for about 6 to 7 weeks to deliver a short burst of radiation. Typically well tolerated, some local problems such as skin reaction, maybe some breast swelling, maybe some fatigue, but overall well tolerated. Over time, we've been looking at, can we make this a little bit better for the patient, the experience better for the patient, and allow the patient to have some choices? So in the early 1990s, we realized that if the cancer is going to come back after a lumpectomy, it's going to come back right in that area, most likely. Very rarely does it come up elsewhere in the breast. And so the thought was, do we really need to treat the whole breast? And if we don't have to treat the whole breast, therefore partial breast, could we do it quicker and accelerate the treatment? So a lot of things have happened since the 1990s. First, we initiated treatments with accelerated partial breast irradiation, where we would treat just the area around the lumpectomy bed twice a day for 5 days, which was a great advance over coming in every day, Monday through Friday, break on the weekends for 6 to 7 weeks. But at about the same time, investigation was going into, can we make whole breast radiotherapy better? Later data came out saying you could increase the dose per day, treat the same whole breast field, and get it done in 3 to 4 weeks, which greatly improved that experience. But simultaneously, back and forth, we also had some advances in accelerated partial breast radiotherapy in 2 ways. One, as of December, we achieved 10-year data presentation from a large 4,200 patient national trial, which showed that the outcome between whole breast radiotherapy and partial breast radiotherapy was equivalent, not only in terms of disease control, but also in regards to cosmetic outcome. And also during that time, we found that using all what we know about radiation, that we could take that twice a day for 5 days and further accelerate it and get that treatment down to only 3 treatments, therefore getting things done in 2 days.
Explain to me how very precise this particular procedure is.
Accelerated partial breast radiotherapy utilizes highly conformal dose delivery approaches to achieve our goals. And the original way we started doing this was with brachytherapy. Brachytherapy is the use of radioactive sources, either temporarily or permanently, within the tissues. Many patients know about it because we've been doing it for a long time in prostate cancer, where we put radioactive sources into the prostate and they stay, deliver the dose over time, and essentially, quote, burn out over time and deliver an effective dose. In the case of breast, we started with a temporary placement of device or some catheters to deliver short bursts of radiation using a radioactive source into a highly defined area twice a day over 5 days. We also have an external beam approach, which delivers the dose to a highly conformal treatment field that has been delivered twice a day for 5 days for a total of 10 treatments, just like the brachytherapy. There also is some data talking about delivering once a day for 5 treatments, but delivering it every other day, so it stretches out after 2.5 weeks. And actually, there's a third technique where they are using some permanent radioactive sources placed within the breast to deliver this dose. So there's a lot of different methods and approaches to deliver this partial breast treatment field. All of them focus on highly conformal fields to the area at risk and accelerating the treatment to get it done safely and effectively so that the patient can move on either for additional treatment or just move on with their life and put this behind them.
So who are the patients who are eligible for this particular treatment approach?
So this treatment approach focuses on the early stage disease. So we're looking for women as candidates for this who have small tumors, less than 3 centimeters, have a lumpectomy that achieves a negative margin, which is what the goal of a lumpectomy is, does not have any positive nodes, and has a cavity that's left behind from the surgeon that's easily identifiable, so we have a target, and is approachable by one of the techniques. Patients that wouldn't be eligible may be appropriate for this are more advanced cancer cases. And then an additional place that we're looking at the utilization of this, which we've recently published a small series from a national trial, is in women who have had traditional whole breast radiotherapy, have subsequently developed a new cancer within that breast, but still want to keep the breast. Traditionally, they go to mastectomy because of the previous radiation. We've shown that the surgeon can repeat a lumpectomy, and we can use this partial breast radiation therapy to continue to preserve the breast and control the cancer effectively. So those are sort of the couple of areas where this may be appropriate.
So APBI can be repeated more than one time?
Depends on the situation, yes. So if you've had partial breast radiotherapy initially and you develop another cancer in that breast, you may be able to do it again. But oftentimes in that situation, we'll do a lumpectomy for the new cancer and then treat the whole breast with radiation. In other words, because you had partial breast doesn't mean that you have to lose the breast if things don't work out in your favor. And reverse of that would be if you've had whole breast radiotherapy and then failed within the breast for whatever reason, a new cancer popped up, you may still be able to keep the breast by going through partial breast radiation.
So as far as benefits go, in addition to the breast not swelling as much with APBI, what other physical benefits are there to using this procedure?
Side effects of radiation therapy are a combination of where we're delivering the radiation, how high the dose is that we're giving, and the volume of tissue that we're treating. So in this particular case, in comparison to whole breast radiotherapy, we're still treating breast tissue, obviously, and we're still giving an effective dose. But the main difference is there's a much smaller volume of tissue being treated. And so we have the ability to decrease the skin dose and decrease the volume of breast tissues getting treated that would lead to swelling and scar tissue, and potentially have less toxicity from the treatment. I will tell you from the national trial, however, that the toxicity was relatively well accepted in whole breast radiotherapy. It's hard to make a lot of improvement, but there may be individuals who we will identify that would be better off with partial breast radiotherapy, such as a woman with a large breast where whole breast radiotherapy may have a bigger impact in a negative way than if we only treated a small volume of tissue. And so we're trying to figure out in whom the toxicity would be less if we did partial breast on a reliable basis.
And you've been involved in these trials. What's going on at the moment that you're testing?
So right now, our biggest thing is trying to move it to an even shorter treatment approach. As I mentioned to you, it has been twice a day for 5 days, which often includes a weekend, and therefore you're looking at about 8 days of having catheters or a device in place, or coming in and out for the external beam approach. Now that we're starting to move to even shorter treatments, which has only recently been found with equivalent toxicity, we're still working through the logistics of that. And so what we're focusing on now is getting it even shorter, trying to get it down to a reliable 2 days so patients can come in, maybe have one night with a device or catheters in place, and then have them removed the next day and move on.
Dr. Douglas Arthur is the chair of radiation oncology at VCU Massey Cancer Center. To learn more about breast cancer care at VCU Massey Cancer Center, visit masseycancercenter.org. That's MASSEY cancercenter.org, or call 877-4-MASSEY. To listen to other podcasts from VCU Health, visit vcuhealth.org/podcast. This is Healthy with VCU Health. I'm Aileen Ellis. Thanks for listening.